Tobacco addiction is a chronic disorder from nicotine dependence, the primary psychoactive component of tobacco. Bupropion inhibits dopamine and norepinephrine reuptake and blocks nicotinic receptors, counteracting withdrawal dysphoria and reducing nicotine reward. This stimulation releases dopamine in the nucleus accumbens, producing pleasure and reinforcement, leading to continued use. Over time, neuroadaptation leads to tolerance and dependence. Withdrawal symptoms like irritability and intense craving make cessation difficult. Managing tobacco dependence requires a combined approach of behavioral and pharmacological strategies. Behavioral interventions like counseling and cognitive behavioral therapy help modify smoking habits and triggers. Pharmacotherapy is crucial for neurochemical dependence, aiming to reduce withdrawal, decrease craving, and facilitate long-term abstinence. Nicotine replacement therapy provides controlled, lower doses of nicotine without harmful tobacco smoke components. NRT maintains plasma nicotine levels to minimize withdrawal and craving, allowing gradual tapering. Various formulations are available. Nicotine gum is chewed using the chew and park method, while transdermal patches deliver nicotine continuously for 16 to 24 hours. Lozenges and sublingual tablets dissolve slowly, providing oral gratification. Nasal sprays and inhalers offer rapid craving relief for heavy smokers. NRT is typically used for 6 to 12 weeks, with gradual dose tapering. Common adverse effects include local irritation and nausea. It is contraindicated in pregnancy and in patients with recent myocardial infarction. Bupropion, an atypical antidepressant, is a major non-nicotine pharmacotherapy effective for smoking cessation. Bupropion inhibits dopamine and norepinephrine reuptake and blocks nicotinic receptors, counteracting withdrawal dysphoria and reducing nicotine reward. Therapy starts 1 week before the quit date at 150 milligrams once daily for 3 days, then 150 milligrams twice daily for 7 to 12 weeks. Common adverse effects include insomnia and dry mouth. Bupropion is contraindicated in patients with seizure disorders or those using MAO inhibitors. Varenicline is another effective agent, a selective partial agonist at alpha, 4, beta, 2 nicotinic receptors. Varenicline provides partial receptor stimulation, alleviating withdrawal, and blocks nicotine binding, preventing rewarding sensations if the person smokes. The regimen involves titration, starting at 0.5 milligrams once daily and increasing to 1 milligram twice daily, continuing for 12 weeks or longer. Frequent adverse effects are nausea, insomnia, and vivid dreams. Psychiatric history should be reviewed due to rare mood changes or suicidal ideation. Varenicline has shown the highest quit rates among pharmacotherapies. Other second-line agents include nortriptyline and clonidine. Nortriptyline, a tricyclic antidepressant, reduces withdrawal symptoms by inhibiting norepinephrine and serotonin reuptake. It is started 10 to 28 days before quitting at 25 to 75 milligrams per day. Its use is limited by side effects like sedation and arrhythmia risk. Clonidine, an alpha-2 adrenergic agonist, helps relieve withdrawal-related anxiety and irritability. Clonidine can be given orally or as a transdermal patch, but hypotension and sedation limit its routine use. Combination pharmacotherapy can be beneficial. A nicotine patch with gum or lozenges improves abstinence rates. Bupropion combined with NRT shows superior efficacy. However, varenicline should not be combined with NRT due to increased adverse reactions. Therapy duration ranges from 8 to 12 weeks, extendable for strong dependence. Certain populations require special considerations. For pregnant women, behavioral counseling is preferred. Pharmacotherapy is used only if benefits outweigh risks. Adolescents are not recommended for pharmacological treatment. NRT can be used cautiously in cardiovascular disease patients. Bupropion is often helpful for psychiatric disorders, but requires mood monitoring. Placebo-controlled studies show abstinence rates. Placebo 5 to 10%, NRT 15 to 20%, bupropion 20 to 25%, and varenicline up to 35%. Combination NRT may achieve higher success rates. Cytisine, a plant-derived nicotinic agonist, is a cost-effective alternative in Europe. Nicotine vaccines are under-researched to prevent nicotine entry into the brain, though results have been inconsistent. Electronic cigarettes are not recommended as cessation aids due to uncertain efficacy and safety concerns. In summary, pharmacotherapy for tobacco addiction involves NRT, bupropion, varenicline, and other agents, often combined with behavioral counseling. Varenicline is the most effective single agent, while combination therapies enhance abstinence rates. An individualized approach offers the best long-term outcome.